I'm now excited to introduce our final speaker, which is Professor Kay Crossley. Kay is a physiotherapist and director at the Trobe Sports and Exercise Science and Medicine Research Group. She strives to make a difference by better understanding knee pain and early onset arthritis. And I'm going to hand it over to you.
Thank you very much. And I'm also going to start by telling you about the poll. And what I want you to think about is whether you think pain medication or exercise is the most effective treatment for knee or hip osteoarthritis. So that's your job, is to think about that. My job is to highlight, I think, the fantastic work that Sue has done and the collaboration between La Trobe and the Australian Ballet, really helping us to understand how the ballet hip works, if you like, and how we can actually help to protect their hips and give them long ballet careers. And then also to apply that work to the general population. So most people who are here, socially distant in the room with me, and all of you, most of you at home, are not ballet dancers, but we all still get hip and knee pain and hip and knee osteoarthritis. So my part is to sort of take the fantastic work that's been done in the ballet and apply it to the more general population. So if we think about the average person who's aged over 50, we see that roughly 1 in 3 of those will have hip or knee pain, and 1 in 4 people will get hip or knee osteoarthritis, and I'm going to probably call that OA from here on in, over their lifetime. So we know it's very, very common, particularly once we hit about 50 years of age. So we've heard a lot about ballet, and Jill mentioned sport, but is sport bad for our hips and knees? Well, we know that being physically active and participating in sport is really, really important. It's good for our mental health, our physical health, and for avoiding all of the chronic diseases that come around if we're not involved in physical activity. But we also know that sports participation is associated with risk. And as highlighted by Jill, if we do have a knee injury, then we will have a higher risk of osteoarthritis. And certainly it's the biggest risk factor for knee osteoarthritis in young people is actually having a knee injury. And if we look at the prevalence of osteoarthritis over time, so on our y-axis, on our vertical axis, there's a prevalence of osteoarthritis. And along the bottom, we have the different ages, and we can see that the older we get, the more likely we are to have osteoarthritis in our knee. But if we've had a knee reconstruction, we can see that line is a lot steeper. And if we sort of highlight people who might be sort of 30 to 40 years of age, we can see that in the uninjured population, about 10% of those might have osteoarthritis, but about 30 or 40% of people who've had a knee injury will actually have osteoarthritis. So we know that the risk of having OA increases over time, but that risk is much steeper if you've had a knee injury. What about other sports, such as running or sports, as mentioned before, where we don't have contact and we don't have injuries? What we do know about load is that, as Jill mentioned at the beginning, is that we need to have the right amount of load. So it's a little bit like the Goldilocks. If we have too much load, then we're likely to get an injury, we're likely to get osteoarthritis. If we have not enough load, then we're also likely to have osteoarthritis. So what we want to have is load, and we've also had highlighted to us how important it is to keep that load up over time. And if we don't have enough, or if we have too much, then we're more likely to have injury. And we see that in running as well. So there's no strong evidence that running itself causes hip or knee osteoarthritis. And what we don't know is if someone already has osteoarthritis, whether they should keep running. We don't know if it's good for you, a bit like we've heard with the ballet, to keep going, or whether in fact we should be doing a bit less. But what we do know is that running does have many, many health benefits. So it prevents at least 35 different health conditions, so brain health, diabetes, and our chronic conditions. So we know that sports participation is important and that the physical activity benefits certainly outweigh the risk of osteoarthritis, but we also know we need to prevent knee injuries. So what are the factors that increase your chances of getting osteoarthritis? Jill's already talked about some of these: getting older, unfortunately, being a woman, and if you've got a family history of osteoarthritis. But what about some of the things you can change? So we've already talked about joint injury. We know that's important. We know that weight is important, so that the heavier we are, the more likely we are to get osteoarthritis. That's not just related to the load on the joints, but also related to the systemic effects of being overweight. And a recurring theme both from Jill and from Sue and from my talk is also muscle weakness. We know that having weaker muscles makes you more likely to get osteoarthritis, but also makes you more likely to have progression of that osteoarthritis over time. So what do people complain of when they've got osteoarthritis? Anyone who's listening at home who has some osteoarthritis will recognise these activities. Putting on our socks and shoes, getting up from a chair, going up and down stairs are difficult activities for us. But again, muscle weakness is a really critical part of this. So we know that if you've got knee osteoarthritis, you're more likely to have weakness in your quadricep muscles. And if you have hip osteoarthritis, you're more likely to have weakness in your hip muscles. And certainly that's one of the things that we've seen in the ballet as well. And in people who've already got osteoarthritis, muscle weakness predicts more pain and decline over time. So some of the other things that you might think about if you've already got hip and knee pain, and some of the things that have been highlighted in the ballet, are things like having less range of motion, inability to perhaps sit as comfortably or to lift your leg up, difficulty getting in and out of a chair, having weakness in your calf muscles, not just in the muscles that are affected around your hip or your knee. Walking slower or shorter steps is a frequent problem for people with hip and knee OA, and also having reduced balance, and we heard about that earlier. So what can we do about it? We've heard about some fantastic results in the ballet, and it's very, very similar in the general population as well. We see that we've got this osteoarthritis treatment pyramid where the big base of the pyramid is where most of the evidence is. So most of the research tells us that education, exercise and weight control, if you're overweight, has the most amount of evidence for it, and it's the thing we should be doing most. After that, we have medication and some passive treatments that I'm going to highlight. And then thirdly, it'll be surgery. So education, exercise and weight control should be the first thing we do, and it should be for everybody. Our second line treatments of medication, some of our passive treatments are our second line, and also they're only for some. And our final treatment that we should be going for is surgery, and very few people should be having that. So we know that most people in Australia don't actually use these best first treatments for osteoarthritis, such as education and exercise. But we also know when people do understand about their hip and knee, they do have a better effect. Exercise has the most evidence of any treatment, as I've already said, and weight management is hard, but it can help. So this slide highlights the different effects of the different treatments. And I've highlighted in orange 3 different types of exercise. So strengthening exercise, endurance exercise, or functional exercise. And you can see those 3 are all better than every other bar there, which is inflammation, weight reduction, and medications. But you'll also see that the 3 are quite similar. So really it doesn't matter what type of exercise you do, as long as you do something. So how much should you do if you're doing sort of physical activity type exercise? You want to do at least 45 minutes of weekly sort of sweating related activity. And certainly even in people with very severe osteoarthritis, they can get 70 minutes of walking a week. So there's no reason, even if you've got arthritis, not to be doing physical activity such as walking. Resistance training is important to build up the muscle strength, and you need to do that at least twice a week. It's safe to improve the functional capacity, and we've heard about that already, and to reduce disability in people with chronic disease. And you don't get more OA by being more physically active. We've heard about pain, and everyone says, well, it already hurts me to walk or to get out of a chair or go up and down stairs. Why would I do exercise? But we know that pain's okay when you're doing some exercise, as long as that pain's acceptable to you. So if you think about a scale of 0 to 10, where 10 could be the most pain you could imagine, something around the 2 to 5 scale. And what we expect is after you've done your exercise, the next day, the pain should go back to where it was before. So some pain during exercise is normal, and it isn't going to damage your joints. So if we know exercise is so good, why don't we do it? There's a whole lot of things here, and I think everyone can relate to those: lack of time, poor motivation, not seeing the results we want. But it's up to us, and I think we heard brilliantly this earlier today from Amber about taking charge of your own body, listening to your body, using techniques that work for you, daily physical activity being important, doing the best exercises, doing the physical activity. If you don't do them, they're not going to make a difference. So it's got to be coming from within. You've got to have the motivation yourself to be able to do the exercise and get the results. If we think exercise is hard, we know weight management is harder, but we know that if we do lose weight, we will reduce pain. And I think for some people, that's a really big motivator. Even small amounts of weight loss will improve your health and reduce your pain. and combining interventions, so eating less with exercising more, but getting support from your friends and your family and possibly a dietitian if that alone isn't going to get you over the line. I'm going to quickly go through medications, so we can have tablets such as paracetamol or ibuprofen. They have very small benefits, but they don't really have a lot of side effects. Injections can have short-term benefits, but they do have adverse events and they may actually damage your joint over time, and nobody should really be taking opioids. The passive treatments are things like massage, a walking stick or a brace, and they can provide some help, but they don't provide as much help as exercise, and they're only to be added to the overall scheme of things. Added to the exercise, not instead, So I think now is the time for our poll results.
Pain medication is at 1.6 and exercise is at 98.4.
Fantastic.
Smart audience out there.
Very smart audience. So I'm going to highlight another research program we're doing here, which is actually delivering exercise and education to the public. It was developed in Denmark and now it's available in Australia, and we're training physios how to provide exercise therapy and education to people with hip and knee osteoarthritis. A couple of final slides on surgery as being the last resort, as we mentioned. The sort of two common types that we see for both hip and knee. The first is the arthroscopy, so the clean-up type operation. In the knee, there's no evidence it's better than any sort of placebo treatment. And while the side effects are rare, they do exist. So most osteoarthritis guidelines around the world actually recommend against this procedure for knee osteoarthritis. Joint replacements are effective. It's where we take the ends of, we don't, but surgeons take the ends of the joint off and replace them with metal and plastic joints. They're big operations, they're high cost, there's a long recovery, but they do work for people with severe OA. But interestingly, in people who have had this GLAD program and other programs like that, they can actually delay having joint replacement for a couple of years. Just going to highlight some of the projects that we are still doing here at La Trobe, or we're continuing to do here. So we're trying to work out if running is in fact bad for your knees. We're testing the optimal rehab following surgery. We're doing research into GLAD Australia and injury prevention. And we're doing very similar in the hip. So we're looking at whether hip pain leads to OA, testing the best rehab, and looking at whether we can prevent hip injuries. So my final slide is just my take-home messages, which I think also encompass everything else we've heard today, is the importance of staying active and staying strong, that muscles are really important to maintain our joint health. Physical activity has lots of benefits, more than just our joint health, and not everyone can be a ballet dancer, but we should all take care of our own bodies. So thank you.
Thank you so much, Kay.